Good afternoon, everyone, and thank you for coming. This is, of course, our 11th annual lecture on aging, and we are very excited today to have Dr. Sonia Ancoli-Israel here as our presenter. She is a professor emeritus and professor of research in the departments of psychiatry and medicine at the University of California, San Diego School of Medicine, director of the Gillen Sleep and Chronomedicine Research Center, and Director of Education at the Sleep Medicine Center at UCSD. So without further ado, I would like to introduce our speaker.
Thank you so much. Thank you, Elton, and thank you especially for the invitation to come and lecture to you. It's really my honor and privilege to be here today to talk to you about my very favorite topic, which is sleep and aging. I feel like I'm distant from you, but my slides are set up here, so I'm going to have to stand on this side rather than standing closer to you. We're filling up here a little bit. So let me start by saying that if you fall asleep while I'm speaking, I never take it personally. I know it means you have a sleep problem, and I'll talk to you about that later. So, having said that, let me start with disclosures. I do consult for many different companies, all of whom have something to do with sleep, but none of that will influence any of my talk to you today. So I'm going to start with this slide. Oh, and I need to apologize to all of you that I actually have a horrible cold, and every once in a while I'm going to stop and cough. So I apologize in advance for all of that. So this slide looks very complicated, but it really isn't. And I'm going to walk you through it because understanding this will help you understand everything you need to know and everything I'm going to tell you about sleep. So this is our theory of sleep. This is what controls our sleep and wake. It's called the circadian and homeostatic regulation of sleep. And it's broken down to the homeostatic part, which is the sleep drive, and then the circadian part. So if we look up here at the sleep drive, and I'm hoping you see the arrow too on both sides? Yeah, good, okay. So when you first wake up in the morning, your sleep drive, or that need to sleep, is very low because you just woke up. As you go throughout the day, that need to sleep increases until it gets to be so high that you can't stay awake anymore. You fall asleep, and once asleep, that sleep need dissipates until the morning when the whole thing starts again. What keeps you from falling asleep here in the early evening as the sleep drive increases? Well, it's the circadian alerting system. It also increases throughout the day. And when it gets sort of to this balance point, you are then able to fall asleep. And then it also decreases. Now, as you can see, there are a couple other curves here. This is our core body temperature curve. Core body temperature drops at night. That's when we get sleepy. Rises in the morning hours, that's when we wake up. But I want to point out this dip in the early afternoon, right about now actually, where our core body temperature drops again. And this is why we tend to be sleepy in the early afternoon. It's not because you ate a big lunch, it's because it's a very normal time for the body to want to take a nap. And of course there are whole societies that do that, right? Societies that take siesta, less and less. Even in Mexico, they're not doing it so much anymore. They used to do it in the Middle East and in Spain, and a lot of them are giving up on it because everybody wants to work all day long. But when they were doing it, if you remember, they tend to have their dinner much later than we do. And in a 24-hour period, they're sleeping the same amount. They just do it in 2 bouts, and we do it in 1. But physiologically speaking, doing it that way with the 2 bouts actually makes more sense because of this circadian dip here. And this last curve here is our melatonin curve. You've all heard of melatonin. You can buy it over the counter. But I'm talking about the intrinsic melatonin, the one we produce in our brain and the pineal gland. And melatonin is our hormone of darkness. It is secreted in darkness. And it also helps us sleep. And later on, when we talk about treatments and things to improve your sleep, we'll come back to that and that idea of darkness at night and how important that is. So it's the combination of all these things that help determine when we're asleep and when we're awake. And when the circadian drive or the sleep drive or the circadian system become out of sync, that's when we start having difficulty sleeping. So this model explains really all you need to know about what makes us sleep at night and keeps us alert during the day. So it's sort of the basics of everything we're going to talk about. So I like using a lot of cartoons. There's so many wonderful sleep cartoons out there. So here's Marvin. Marvin was playing a game with his grandpa, and he thinks, Grandpa fell asleep playing with me. I better put these someplace for safekeeping. And he takes Grandpa's glasses. And of course, it's not the glasses that I care about here. It's the fact that Grandpa fell asleep while playing a game with his grandson. And people think this is funny, thus a cartoon. But what's worse is people think this is normal behavior. Just because Grandpa is old, it's okay that he fell asleep playing a game. And if you don't remember anything else from my talk this afternoon, remember this. This is never normal behavior, no matter what the age of the individual. And we'll review, as I go through my lecture, of the different reasons why Grandpa may have fallen asleep at this very inappropriate time. So there's always a question of how much sleep people need and whether that amount changes as we get older. These are data from the National Sleep Foundation, which is a nonprofit organization whose mission it is to educate the public about sleep. And every year they do a survey. In 2003, the survey was on sleep in older adults. Unfortunately, they defined older as 55. I fought them on that, but I lost. So what we have here is the blue are data from a previous survey in younger adults, aged 18 to 54. The pink is 55 to 64. The yellow is 65 to 84. And the orange is the combination of these two groups. So it's all what they called older adults. And what we see here is on weeknights, the younger adults are sleeping under 7 hours, and the older adults are sleeping right at 7. So if nothing else, just from this part of the plot, it certainly doesn't look like older adults are sleeping less than younger adults, does it? On the weekends, the younger adults are sleeping much more. They're a little over 7.5 hours. And that's because they're sleep deprived, because 6.5 isn't enough sleep. And so they're trying to make up for it on the weekend. But the older adults stay right at 7 hours. And this, it's data such as these that helped us understand that older adults don't necessarily sleep less than their younger counterparts. And there was another study. So there are changes, however, that occur in sleep, even though the amount of sleep should not change. And there was a lovely meta-analysis of over 3,500 adults aged 5 to 102, looking at changes in our sleep architecture. And what they found was that sleep actually remains fairly constant from age 60 and up, except for sleep efficiency. So I'm going to show you what this looks like. So slow wave sleep, which is a very deepest level of sleep, was always thought to be decreased in older adults. And what we can see from this meta-analysis is that, in fact, slow wave sleep begins decreasing in our 30s. So I'd venture to say for most of us in this room, we've already started losing our deep sleep. And once you get to that point, it actually remains fairly stable after that. So it's not just older adults that have decreased slow wave sleep. It's pretty much all middle-aged adults and up that have the decreased slow wave sleep. But sleep efficiency does seem to decrease. Sleep efficiency is defined as the amount of sleep given the amount of time that you're in bed. Do you want me to stop wandering because of that? All right. So in the ideal world, that would be 100%, right? You'd be asleep the entire night. But it takes everybody at least a few minutes to fall asleep. Everybody wakes up once or twice during the night. So we consider a sleep efficiency of 90% or above to be good sleep efficiency. And as you can see, with age in both men and women, sleep efficiency does drop. So something is certainly going on in our sleep as we get older, even though the need for sleep may not be changing. And the reason we care about these changes in sleep is that there are consequences to not getting enough sleep at night. These would include problems with attention, slower response time. And I always like to point out when I talk about a response time, I'm not talking about how long it takes someone to push a button in response to a stimuli in a laboratory. I'm talking about how fast can that person slam on the brakes when a child is running in front of their car. That's a response time. And that gets slower with disturbed sleep or insufficient sleep at night. Difficulty with memory, with daytime performance, and there's a higher risk of developing depression, poor physical function, and these studies were actually done in older adults. So poor physical function was defined as the ability to get out of a chair on their own or the ability to walk down a narrow path, which has to do, of course, with balance. And that all decreases, or higher risk of that decreasing with poor sleep. Higher risk of cognitive impairment, of falls, and of mortality. So none of these are good things. And the bigger problem is when you see these symptoms in the older adult, you begin to think that it's dementia, when in fact it may not be. It may just be a result of insufficient or disturbed sleep at night. And it's really important to be aware of that to be able to make the distinction in the diagnoses. So, why does sleep deteriorate as we get older? Is it the aging process itself? Is that why? And the answer to that is no. Aging per se does not cause sleep problems. What does cause sleep problems is all the other things that happen to us as we get older. And that's what I want to review now for the rest of the talk. So the things that make it harder for us to get the sleep that we need as we get older include medical and psychiatric illnesses, the polypharmacy, all the medications that we take, changes in our circadian rhythms, and the high prevalence of primary sleep disorders. So let's look at these. Let's start with medical problems. Just about any medical condition that causes discomfort can have an effect and be associated with disturbed sleep, whether it's the pain of headaches, arthritis, neuropathy, cancer, whether it's the neurodegenerative diseases like Alzheimer's or Parkinson's or MS, whether it's congestive heart failure, nocturia. I mean, there's one that's an obvious one that's going to disrupt sleep at night. And by the way, nocturia is defined as having to go to the bathroom 2 or more times a night. And it's rarely recognized or even asked about of patients. But it's a problem, and it obviously disturbs sleep. So for those of you that see patients, or even in yourselves, I want you to think about how many of these disorders do older patients have? Probably, if you're thinking about this, you know the answer is multiple disorders. And therefore, they're going to be at a higher risk for also having disturbed sleep. In that same study from the National Sleep Foundation, we looked at the relationship of multiple disorders with sleep. So here we're looking at no medical disorders. The pink is 1, the yellow is 2 or 3, and the orange is 4 or more. And our categories here are those that reported sleeping less than 6 hours a night, those that reported any insomnia, or those that reported excessive daytime sleepiness. That's what EDS is. And as you see, especially with insomnia, but really with all of them, the more medical disorders a person had, the more likely they were to have some difficulty with sleep at night. And so it's very important in our patients, our older patients, to make sure that we're not only treating the medical or psychiatric conditions, but we're also addressing and treating any of the sleep problems that might be occurring. Okay, here's another Marvin cartoon. He's sitting with his little cousin, and he says, "How come Grandpa never goes to a job like other big people?" And his cousin says, "'Cause he works at home, silly. See, he runs a drugstore." So polypharmacy, a real problem. The older we get, the sicker we get, the more medications we use, and all these medications also contribute to the decreased ability to get the sleep that we need. So I'm going to start with alcohol. You may or may not consider it a medication, but it's certainly a substance. And many older adults will use alcohol to help them go to sleep at night. And alcohol does make you sleepy initially. But several hours later, when the alcohol leaves your bloodstream, it wakes you right back up again. Alcohol causes insomnia. Let's say you drink a lot with dinner. You might be sleepy initially right after dinner, but several hours later, when it's time to go to bed, you're going to be wide awake. So it's important to check with patients about how much alcohol they're drinking, not in terms of are they abusing it, but in terms of their sleep. Caffeine, you've all heard about the issues of caffeine, and I can't tell you how many people say to me, oh, I can have a double espresso at bedtime, it doesn't bother me. Well, if I recorded your sleep and showed it to you, you would find that, yes, in fact, it does bother you. And remember, caffeine is not just coffee. Decaf coffee still has caffeine in it. Teas. It's funny, I ask my patients, do you drink any tea? And they'll go, no. And then I'll go, how about iced tea? Oh, yeah, every day with lunch. I guess iced tea is not the same as tea. You have to ask it that way when you ask your patients. Sodas, and a soda doesn't have to be brown. Mountain Dew has more caffeine than Coke. Diet Coke has more caffeine than a regular Coke. So you have to know these things and ask your patients. And then nicotine, in case people don't have enough reasons to stop smoking, there's one more. Nicotine also disrupts sleep. But look at our prescription medications. Antidepressants, corticosteroids, decongestants, beta agonists, beta antagonists, statins, et cetera, et cetera. Think again about your older patients. How many of them are taking at least one of these classes of medication? How many are taking more than one? Probably most of them. And this also will then contribute to their difficulty getting the sleep that they need at night. And what we usually suggest is change the time of day that these medications are taking. So the stimulating medications should be taken earlier in the day, the sedating ones can be taken later in the day, and decrease the dose. And that often, all on its own, will help improve sleep. Okay, so we've talked about the medical and psychiatric illnesses and the medications, polypharmacy, contributing to that difficulty getting the sleep that we need. The next category are changes in our circadian rhythm, and this explains why, as we get older, we tend to fall asleep more often in the opera and the symphony. And Benjamin Franklin was wise enough to say, early to bed and early to rise, and of course he went on to say, makes a man healthy, wealthy, and wise. But it's that first part that describes exactly what happens to our sleep as we get older. So this takes us to the discussion of circadian rhythms, our biological clock. Circadian is from the Greek meaning about a day, so it's our 24-hour rhythm, and there are many things in our body that have circadian rhythms: core body temperature, blood pressure, many of our hormones, and of course sleep-wake is one of our 24-hour rhythms. So the typical pattern for most adults is that we get sleepy somewhere around 10 or 11. And as I mentioned earlier, that's when our core body temperature drops. We sleep for about 7 to 8 hours, which is the amount of sleep that adults need. And so we wake up somewhere around 6 or 7 in the morning. But at different times in our life, this pattern changes. How many of you have teenagers or used to have teenagers? How many of you used to be teenagers? Okay, so you may remember in yourself or in your kids wanting to stay up till 1 in the morning, sleeping until noon, and then as parents, we used to yell at our kids and say, stop being so lazy, you're sleeping the whole day away, right? Well, it turns out that this pattern of staying up till very late and sleeping into the late morning hours is very common in teenagers and young adults. It's called delayed sleep phase. And what's happening here is their circadian rhythm has delayed compared to this typical phase and is now out of sync with the environment. So people who are phase delayed don't get sleepy. Their core body temperature doesn't drop till maybe somewhere 1, 2, sometimes even later in the morning hours. And if they went to bed at that point, they would fall asleep, they would have no trouble sleeping. But if you do the math, remember, teenagers actually need 9 to 10 hours of sleep as opposed to us who need 7 to 8. So if you're not going to bed till 1 or 2, you are in fact going to sleep late into the morning hours or even as late as noon. And this is very, very common in that age group. Now here's what happens. If they try to go to bed at 11 or even 12, they have a very hard time falling asleep. They think they have insomnia. I have so many young adults coming to see me saying, I have terrible insomnia. It takes me hours to fall asleep. And it does take them hours because their body is not ready to go to sleep till here. And then they have a very hard time getting up in the morning because their body isn't ready to get up yet. So this is called delayed sleep phase. As I said, it's very common in teenagers, young adults, college-age students. Most people outgrow this. As we grow into adulthood, the pattern advances back to this typical phase, but some people stay delayed their whole lives. And we now know there's a genetic component to that as well. So, and we call these people our owls. How many of you are owls? Yeah, when you're an owl, you know you're an owl. So stick with me, because in a minute I'm going to tell you how you can shift your rhythm if you want to. So, as I said, most people shift back or advance back to this typical phase, but as we continue to get older, the pattern continues to advance, so that older adults have advanced sleep phase. Their core body temperature is dropping earlier in the evening, maybe 6, 7, 8 o'clock at night, and if they went to bed at that hour, again, they'd have no trouble falling asleep. They would sleep their 7 to 8 hours, but do the math. What does that mean? They're going to wake up at 3, 4 in the morning. What is the biggest complaint our older patients have about their sleep? I'm waking up in the middle of the night, here it is, right here, and I can't get back to sleep. And they can't get back to sleep because physiologically speaking, their night is done. Doesn't matter that the sun hasn't come up yet. It's finished. There's no way they're going to get back to sleep. Now, two things happen here. One is, even though they might get sleepy early in the evening, they're not going to bed at 7 o'clock or 8 o'clock, right? It's not appropriate. First of all, they're used to staying up later. Second of all, they want to have some life. They want to go out with their friends. They want to go to the symphony where they're going to sleep anyway, but nevertheless. So they force themselves to stay up till maybe 10 or 11. They fall asleep, but they still wake up at 4 in the morning. Now, they're not in bed long enough to get a full night's sleep. You can't get 7 to 8 hours of sleep if you're only in bed for 5. So during the day, they're tired. They might take an afternoon nap somewhere up here, out here. Now remember our homeostat, our sleep drive? That nap allows them to stay alert later into the evening. So now they get into the cycle of not sleeping enough at night and needing to nap during the day. Second scenario, they come home in the evening, they sit down, they have dinner, and after dinner, they sit down to read or watch TV, and what happens? They fall asleep. And they sleep for maybe half an hour, maybe even an hour. By the way, when I ask my patients, do you nap in the evening? And they go, oh, no, because it turns out sleeping in front of the TV doesn't count as a nap, right? So they sleep for half an hour, maybe an hour. Then they get up, they get ready for bed, they get into bed, and what happens now? Wide awake. That's our homeostat again, right? They haven't been awake long enough to be sleepy enough to be able to fall back to sleep. They haven't had enough time for that sleep drive to build up to allow them to fall back to sleep. So now they complain about difficulty falling asleep when they get into bed at 10 at night, and they're still waking up early in the morning. And they go see their doctor and they say, Doc, I have terrible insomnia. I can't fall asleep, I can't stay asleep, which is the definition of insomnia. But this is not insomnia. This is advanced sleep phase in combination with some very poor sleep habits, which is that napping in front of the TV in the evening. And the treatment for this is going to be very different than any treatment for insomnia. So this is very, very common. This is a very common pattern. Sorry, in our older adults. So what do we do about this? So for our owls, the way we advance your rhythm, help you get sleepy earlier and wake up earlier, is a combination of melatonin and bright light. Melatonin, I told you melatonin is a hormone that we produce, but obviously you can buy it over the counter as well. It is a lousy sleeping pill. A lot of people buy it to use to help them fall asleep. We're not using it that way. In fact, we use a very, very low dose With melatonin, lower is actually more effective than higher. We use I'm so sorry, 0.25 milligrams taken at 6 p.m. every night. And what that does is it helps pull the rhythm this way. In combination with that, you can do morning light. Our best source of light during the day, of course, is the sun. So the best thing to do is get outside in the morning. And when I say in the morning, it's not when the alarm clock wakes you up. It's when your body is normally waking up. That's when you need the light exposure. And that helps push the rhythm this way. And when you go out for your morning light, it has to be without sunglasses because the mechanism is through the eyes. The light goes through the eyes, through the retinohypothalamic tract, to the suprachiasmatic nucleus, which is where our master clock lives. So no sunglasses in the morning. And then you do want sunglasses later in the day to block the afternoon light. So that's a way to advance your rhythm if you're an owl. What about for our older adults who are advanced? For them, we use late afternoon or evening light. The sun isn't always out, so they either have to use a light box or go out as late in the day as possible while the sun is still out to get their bright light exposure. And the afternoon light will delay the rhythm. It'll help them stay alert later and sleep later into the morning. Notice we don't use melatonin for the advanced phase. If we did, we'd have to give it in the morning hours. And even though it's a lousy sleeping pill, it can be a little sedating, and you never want to give anything that's sedating, especially to an older adult in the morning. So we do not use melatonin, we use just light. Now, what happens? These older adults are getting up in the morning, and what do they tend to do? They love going for an early morning walk, right? So now they're getting exposed to light in the morning, which is going to advance them even more. So what you need to advise them is, you don't want them to stop walking. It's great that they're exercising, but they need to wear dark glasses, sunglasses in the morning when they go out, and then go back out again later in the day without sunglasses. And then that helps delay the advanced rhythm. So these are our owls, these are our morning larks, and this advanced phase is yet another reason why older adults have a harder time getting the sleep that they need. All right, so I'm going to shift now to different primary sleep disorders. There's a whole bunch I want to review with you, specifically some that tend to be more common in the older adult. So we'll start with insomnia. The official definition of insomnia is difficulty falling asleep, difficulty staying asleep, waking up earlier than you want to, or having a hard time getting on a set appropriate schedule without having someone else interfere. But it's not enough that you have difficulty sleeping at night. That poor sleep also has to have some daytime consequence before a diagnosis is made. So the patients have to report either fatigue, problems with attention, concentration, memory, impaired relationships with family and friends, disturbed mood, irritability, apathy, being sleepy during the day. Most insomniacs are not sleepy during the day. We know now that insomniacs tend to have hyperarousal, and that same reason they can't sleep at night, they often can't sleep in the day either. They might be tired, but rarely can they nap or sleep during the day. Hyperactivity, impulsivity, aggression, problems with motivation, more likely to have accidents or make errors, and this has to do with not being able to concentrate or pay attention, or even just concerns about sleep. So you have to have one of those along with the difficulty sleeping at night for the diagnosis to be made, and you have to have had the symptoms 3 times a week or more for at least 3 months before we will give you a diagnosis of an insomnia. So how common is insomnia? In the older adult, much more common than in younger adults. We know from many studies that it's somewhere around 50% or more of older adults will have insomnia. But, and this is an important but, these chronic sleep disturbance are almost always associated with poor health. It's that comorbidity of the health issues and the sleep. And in fact, in this study, Dan Foley followed about 2,000 older adults who had chronic insomnia, and 2 years later, half of them no longer had sleeping difficulties, and that half that improved in their sleep also had improved health. So health and sleep are very closely tied together. It's not necessarily a cause and effect. We don't know which came first. It could be either one. We talk about them being comorbid. They occur together. And Foley concluded from these data that the data do not support a model of incident insomnia caused by the aging process per se. It is not aging that causes our difficulty sleeping. As I said before, it's all the things that happen to us as we age that cause our sleeping difficulties. Healthy older adults rarely have problems sleeping. So what do we do to treat insomnia? The best treatment for insomnia is cognitive behavioral therapy, much more effective than sleeping pills, and the duration of the treatment lasts much longer than that of sleeping pills. And there are different approaches. We use a combination of what's called sleep restriction therapy and stimulus control therapy, which I don't really have enough time to go into today. But if you have to synthesize it, it comes down to these 4 points. Reduce your time in bed. 8 hours of sleep out of 8.5 hours in bed is much more efficient than 8 hours of sleep out of 9 or 10 hours in bed. What does the insomniac do? Oh, you know, I didn't sleep a wink last night. I'm going to go to bed 2 hours earlier to try to get more sleep. You're making sleep worse. So you actually want to restrict your time in bed to that amount that you want to sleep. Get up at the same time every day. Keep a very regular schedule. That means 7 days a week. No sleeping in on Sunday if you have insomnia. No matter how much or how little sleep you had the night before, you always get up at the same time every day. And that goes back to our sleep drive. If you sleep in the morning, you're not awake long enough for that sleep drive to be high enough to help you fall asleep the next night. If you get up at the same time every day, even if you didn't get a full night's sleep, your sleep drive will actually be higher, and you'll fall asleep faster and stay asleep longer the next night. Don't go to bed unless you're sleeping. This is especially important for owls, but everybody. If you're not sleepy, you shouldn't be going to bed, because all that's going to happen is you're going to toss and turn and not be able to fall asleep. And don't stay in bed unless you're asleep. You shouldn't be awake in bed ever, tossing and turning and feeling tense and upset about not sleeping, because that just perpetuates the insomnia. So if you find yourself starting to toss and turn, you get out of bed, you go into another room, you do something that's relaxing for you, and you don't go back to bed until you feel your eyes closing. When you get back to bed, if suddenly you still haven't fallen asleep in a reasonable amount of time, which is about 20 minutes, but it's really that when you start getting tense again, you get back out of bed. And you do this all night long if necessary until you can get into bed and fall asleep. You still get up at the same time in the morning. You may not have fallen asleep till 5, but if 6 is when you're supposed to get up, you get up at 6. No napping that day. Next night, your sleep drive will be much higher, and you'll have an easier time falling asleep. If not, you do it again. Both of these, and that's the stimulus control part. Reducing your time in bed is the sleep restriction part. And both of these can take up to about a month to work. I've had some patients within a week or two, but there's no magic bullet. It does take time, but these are very, very effective for the treatment of insomnia. So tell me, somebody call it up. What's the first thing you do when you wake up at night? Look at your phone, right. Most people say go to the bathroom, and I have to tell them they're wrong. The first thing you do is you look at the clock. These days, for most young adults, that's on their phone. For the rest of us, it's actually a clock by our bed. Now, what do you have to do to check the time? First of all, you have to open your eyes, right? You got to lift your head, turn your head, maybe even lift it in order to wake yourself up enough to comprehend that it's 1:20 in the morning and you want to be asleep. You've now made it much harder to go back to sleep. This is our homeostat again. You're not going to be awake long enough for your sleep drive to be high enough to allow you to fall back to sleep. So, you got to get rid of your clocks. Clocks do not belong in the bedroom. You know, cover the TV that has the clock on it. Get your clock out of there. If you need an alarm, stick it under the bed or in a drawer where you're not tempted to look at it. And phones and computers definitely don't belong in the bedroom. That's sort of one of our rules. The bed is for sleeping and sex. But even with that, I say only if it's satisfying. Otherwise, you don't do that in bed either. But it's certainly not for reading, watching TV, paying bills, playing games on your phone, reading emails, etc. That doesn't belong in the bedroom. If, when you wake up at night, you could keep your eyes closed, don't even open them, then you stay in transitional sleep, and there's a much, what we call N1 sleep, and a much greater chance that you'll fall right back to sleep again. As soon as you open your eyes and take yourself to full awakening, it's much harder. Now, some of you are going to say, but when I wake up, I have to go to the bathroom. So the truth is, usually you don't. Usually once you're awake, you realize there's some pressure, and you think, I have to go to the bathroom. Rarely does it wake you up. So again, if you can keep your eyes closed and just go right back to sleep, you might not even have to get up to go to the bathroom. If you do, make sure not to turn on lights. Remember, lights are bad at night. They tell our brain to stop secreting melatonin and wake up. Use a night light, especially for older adults. You don't want them falling, so you might have them use a night light. Actually, I don't think I have a picture here. I found this, did I put it in? No. I have this wonderful picture that I got from one of the airplane magazines. It's a pair of slippers with lights at the tip. Like, God, that's brilliant. I don't know why I didn't buy a pair, because then you could see where you're going without having to turn on lights. So, bottom line is you don't want to turn on lights if you do get up at night. All right, caffeine. I'm pretty sure this one's Mrs. Bear and this one's Mr. Bear. And she says to him, how many times have I told you no coffee after September? Well, we already talked about the problems of caffeine. For people with insomnia, we say no caffeine after lunch. And then the environment is really important. Again, we don't want light, so we want dark curtains, no noise, or if there is noise in your environment that you can't control, then some white, steady noise to help block that, and a very comfortable room temperature, which is different for different people, which is a problem for some couples when, you know, he wants the room hotter and she wants the room colder. You got to find a way to work that out or go into a separate bedroom. But you got to make your environment as comfortable as possible and as dark as possible, again, so our melatonin is secreted. Okay, I want to touch briefly on medication since we're talking about insomnia. Diphenhydramine is probably the most common sleeping aid that's used. It's all those PM drugs that people buy. The advantage is that you can buy it over the counter, and it's cheap, and it's perceived as being safer because you can get it without a prescription. Turns out that's not really true. Disadvantages are the hypnotic dose is not well defined. You often get tolerance. And look at this list of adverse effects. Sedation, grogginess, dry mouth, blurred vision, urinary retention, psychomotor impairment, dizziness, incoordination, delirium. Do you want to see this in your older adult? I don't think so. There is a study done with hospitalized older adults who were in the hospital for all the same reasons that people go in. These were not demented older adults. They were given diphenhydramine, 25 to 50 milligrams, which is what you find in the PM drugs. 68% of the time they were given this drug as an indication for sleep. And this is what the doctors recorded, or the nurses, I forget who recorded it, the next day. Delirium, inattention, disorganized speech, altered consciousness, behavioral disturbance. Not good things, and this was all because of the diphenhydramine. These PM drugs are not good sleeping aids. The NIH in 2005 held a conference, a State of the Science conference on insomnia. They concluded that there's no systematic evidence for antihistamines having any efficacy, and there are significant concerns about the risks. They also said the same thing about antidepressants, which are all often used in non-depressed insomniacs because they happen to also be sedating. So an antidepressant in a depressed insomniac is fine. In a non-depressed, it's not. All antidepressants have potentially significant adverse effects, raising concerns about the risk-benefit ratio, and barbiturates, which shouldn't be used for any reason, and antipsychotics in someone who is not psychotic have significant risks and should not be used for insomnia. So what that leaves is a whole bunch of drugs which are approved by the FDA for insomnia. I'm just listing here the more recent ones. There's some older ones that I haven't listed here. And I'm not going to go through each one, but the key is, notice that some are approved for initiating sleep, some are approved for maintaining sleep, some for both. Some you can take when you only have a limited amount of time in bed, but for most of them you need 7 to 8 hours. So the question you need to ask yourself about the patient is, first of all, what is the patient's problem? Is it difficulty falling asleep, staying asleep, or both? And how many hours does that patient have to devote to being in bed? If it doesn't match this, then these drugs are wrong for that patient, and they could end up having more problems with the drug than help. And as I said, although these have all been shown to be effective in clinical trials, the behavioral treatments are much more effective than any of the sleeping pills. Okay, I'm going to move on. I see I'm almost out of time, and I have a couple more things I still want to review with you. So here's another cartoon. The guy says, I dreamt I was driving down a mountain road and the brakes failed. During REM sleep, when we're dreaming, we are paralyzed, except for our eyes and our respiration. And this is actually a protective mechanism which keeps us from acting out our dreams. So you don't push the bed rail out when you're dreaming. But there is a disorder called REM Behavior Disorder, where that atonia of REM is missing, and these people do act out their dreams. So here's a case. This is a true case. A 60-year-old surgeon began to punch and kick his wife, jump out of bed during nightmares of being attacked by criminals, terrorists, and monsters who always tried to kill me. Work-related stress was the presumed cause of his sleep disturbance, but the violent behaviors intensified despite retirement 3 years later. He sustained several head lacerations. His wife once had a headache for 2 days after receiving an accidental blow to the ear. Proper diagnosis was established after 11 years. Gosh. And a prodrome of excessive limb and body jerking during sleep had been present for 33 years. Somebody missed a diagnosis in here. But this is REM behavior disorder. These people do act out their dreams. They often hurt themselves and their bed partners. And the reason I tell you about this in a lecture about aging is that it's much more common in older men. See it in women too, but it's most common in older men. Now, we also have learned since then that if you see REM behavior disorder in younger adults, it is often a sign that they're going to develop Parkinson's disease. There's a very close connection there. But you often see older men without Parkinson's who also have REM behavior disorder. And the way we treat it is either with clonazepam, which works most of the time, or with high doses of melatonin. This is the only time you would use a high dose. And this is the second. So the only 2 times I ever would recommend melatonin is for jet lag or the delayed sleep phase or for REM behavior disorder. So there are treatments for RBD. Restless leg syndrome is another disorder where people have creepy, crawly feelings in their legs, which is only removed by movement. In order to get the diagnosis, you have to answer yes to all 4 of these questions. Do you have or have you sometimes experienced recurrent uncomfortable feelings or sensations in your legs while sitting or lying down? Do you have or have you sometimes experienced a recurrent need or urge to move your legs? Do these uncomfortable feelings disappear or improve when you're active or moving around? And are these urges worse in the evening or at night compared to the morning? If a patient says yes to all 4, they have restless leg syndrome. Also much more common in the older adult. Each color here is another study, and they're looking at age, and you can see in all of them except this last one, the prevalence increased with age. There are treatments for RLS. We use primarily the dopamine agonists. Sometimes gabapentin is also used, and you start with a low dose and you slowly increase. Notice these doses are much lower than what would be used in something like Parkinson's disease. And also they're taken only at night, which is another difference than the Parkinson's patients. But you also have to be aware that there are many medications that make RLS worse, such as some of the over-the-counter antihistamines, some of the anti-nausea medications, some of the antidepressants, et cetera. So sometimes a person might have RLS because they're on one of these medications, and if you take them off, the RLS might go away. All right, so here's where I really wanted to end up, and that's with sleep apnea or sleep-disordered breathing. Two primary symptoms are excessive daytime sleepiness, falling asleep at inappropriate times, and very loud snoring. Now, I have to tell you something about this photograph. I took this picture when I was in Vienna. This is Brahms, right, the composer of Brahms' Lullaby. And I'm pretty sure Brahms had sleep apnea. Why do I think so? First of all, he's overweight. Most people who are overweight, not all, but most people who are overweight have sleep apnea. By the way, you don't have to be overweight. We have very slender patients who might also have sleep apnea. He has a gray beard, suggesting that he's older. Age is one of the primary risk factors for sleep apnea. As I'll show you in a minute, the prevalence is way higher in the older adult than in the younger adult. Probably has a double chin under that beard, which is also very common in apnea patients. But most of all, he's sound asleep. Who has a statue made of them sound asleep, right? So I'm pretty sure Brahms had sleep apnea. But really the point I wanted to make here is that age is one of the biggest factors. This is a study from these are results from a very large study of older men, the Mr. Oz study. And what we showed here is that 26% of older men had stopped breathing at least 15 times per hour of sleep. I should back up. Does everybody know what sleep apnea is? So this is a condition where people stop breathing in their sleep. You fall asleep, the muscles of your airway collapse. In order to start breathing again, you have to wake up, you start breathing, you go back to sleep, you stop breathing. And this goes on throughout the night. By definition, you have to stop breathing at least 5 times per hour of sleep before a diagnosis is made. So in the older adult, 26% stop breathing at least 15 times per hour, 60% stop breathing at least 5, which I just told you is the cutoff for a diagnosis. This is very, very common in the older adult. And the prevalence of the more severe apnea increased with each increasing age quartile. Very, very common. And one of the main reasons in the older adult why it gets harder to get the sleep that we need. We don't know exactly why the prevalence increases with age. We do know that changes in the airway occur with age. As you've probably already read while I was coughing, the soft palate gets longer, the pharyngeal fat pads increase in size, etc. And all these things result in a smaller airway and puts people at greater risk for sleep apnea. So, since it's so common, is it pathological? There are a lot of studies showing the risk factors of apnea, one of which is cognitive impairment. So this is a cross-sectional study in another large epidemiological study of older women. And here in this study, we found that having sleep apnea was associated with cognitive impairment, which in this study was measured with the MMSC. So stopping to breathe 15 times or more put you at 1.5 times the risk of cognitive impairment. Stopping to breathe 30 times or more, which would be considered severe apnea, is almost 3.5 times the risk of being cognitively impaired. And having your oxygen drop, which often happens with sleep apnea, also is close to 3 times the risk. And each standard deviation increase in the amount of apnea at night was associated with a 70% greater odds of cognitive impairment. But this was a cross-sectional study. What's even more interesting is this prospective study, also done with this large group of older women, where we looked at women who had apnea and did not have apnea, and 5 years later found that those who had apnea were more likely to develop mild cognitive impairment or dementia. You can see it was 31% versus almost 45% that developed a cognitive impairment. And having more desaturations at night, that is, less oxygen, was associated with a higher risk of developing MCI or dementia. Interestingly, in this study, measures of sleep fragmentations, like how often they woke up or how long they slept at night, was not associated with risk of cognitive impairment, although in previous studies it was. In this one, it was not. It was really the apnea and the oxygenation, the lack of oxygen at night, that was associated with this problem. We know from many of our own studies as well that sleep apnea and dementia are very related. In a study of severely demented patients living in a nursing home, 90%, that's just about everybody, had stopped breathing at least 5 times an hour, and their mean was 32. 63% stopped breathing at least 15 times an hour with a mean of 40. Half of them stopped breathing 20 times with a mean of 47. 47 times an hour that they stopped breathing. And the more severe the Alzheimer's, the more severe the apnea, and vice versa, the more severe the apnea, the more severe the dementia. So we became very interested in figuring out what would happen if we treated apnea in patients with Alzheimer's disease. We left the nursing home. We did this in community dwelling patients with mild to moderate Alzheimer's and sleep apnea. We gave them 3 weeks of real PAP treatment, which is the way we treat apnea, versus a sham placebo PAP. And what we found was that those who were treated, first of all, improved in the amount of apnea. That's what you're seeing here. So this is baseline. Here they're put on PAP and they come down to normal levels. Here's baseline. This was the placebo. This is not a significant increase, so it stayed high. But as soon as they were switched to real treatment, it came down. So we improved their apnea. We improved their daytime sleepiness. They began sleeping deeper. They had less of the lighter stages of sleep and more of the deeper stages of sleep. And it improved cognitive functioning. As I said this morning, I didn't cure Alzheimer's disease, but we were able to improve some of the cognitive functioning, which was tested with a complete neuropsychological test battery. And those that continued using the PAP for 6 months after the end of the study had a slower rate of progression of their dementia. So imagine if, actually I don't want to come to that yet. Imagine if you can treat Alzheimer's patients and have all these effects. Imagine if you treated non-Alzheimer's older adults. Apnea is extremely common in the older adult, and it deserves to be treated. So when do you treat apnea in the elderly? The bottom line is, if it's associated with clinical symptoms, then it needs to be treated. It doesn't matter what the age of the patient is. If they're excessively sleepy during the day, if they have hypertension, cognitive dysfunction, nocturia, cardiac disease, or just high levels of apnea, then they need to be treated. They will tolerate the treatment. This is actually one of our patients with Alzheimer's wearing his CPAP mask. They will tolerate it. You have to work with them a little bit, but it can be done. So I was asked to also, I'm running out of time. Am I okay? Okay. I will have, yeah, I'll definitely leave time for, I'm going to go through this very quick. This is the very end. I was asked to give you a list of questions that you should be asking your patients. So you want to get a complete sleep history, including what complaints they have about their sleep and their sleep schedule. So you're going to ask, do you have trouble falling asleep or staying asleep? Does it affect your ability to function? Do you fall asleep at inappropriate times? There's something called the Epworth Sleepiness Scale. You can get it online. It's 8 questions that rate how likely someone is to fall asleep at inappropriate times. If you could go to sleep or wake up at any time, what time would you choose? That's determining if they're owls or larks. What time do you go to bed versus what time do you go to sleep? In other words, are you spending too much time in bed awake? And the same thing in the morning. What time do you wake up and do you get out of bed right away or not? Ask about their alcohol, caffeine, nicotine use, all the medications they're taking, including over-the-counter and illicit drugs, What other medical, psychiatric conditions do they have, and recent life stresses. And then ask about symptoms of the sleep disorders. Do they kick their legs? So do they have restless legs? Have been told that they snore, or has someone observed that they stop breathing during sleep? And when you've tried everything else that we've been teaching you and your patient still has difficulty, or if you suspect apnea, narcolepsy, another sleep disorder, or REM behavior disorder, then you should refer them to a sleep specialist. So the bottom line, it is not aging per se that results in poor sleep, but rather all the things that go along with aging. Although the need to sleep doesn't change, the ability to get that sleep does. Poor sleep in the older adult is most often associated with medical and psychiatric problems, polypharmacy, primary sleep disorders, and circadian rhythm changes. And no matter what the age of the patient, sleep disorders should be treated if they're interfering with the quality of life or if there's a medical risk associated with that. So with that, I have to give you my favorite quote. I always end with this. Aging seems to be the only available way to live a long life. So I wish you good aging along with some very good sleep. Thank you.
Do any of the medications, such as Ambien and Lunesta, advocated for long-term use or short-term?
Ambien is short-term, Lunesta is approved for long-term, and the difference is really political. Ambien is not that different from Lunesta in the way they're both GABA drugs. It's just that it got to a point where the FDA was finally convinced that these drugs could be used long-term, so the newer ones that were approved after that were all approved for long-term. So Ambien is approved for short-term, but really can be used long-term if it is working. And if it's not, then it shouldn't be used.
What do you think of the stop bang as a screening form?
The stop bang?
Stop bang.
So stop bang is a questionnaire that screens for sleep apnea. There are a couple of others. If you don't have any way to do a sleep recording, then that's a good start, but I wouldn't make a diagnosis based on that. But for screening, it's not too bad. Right, if it's positive, you can refer. Right, right. That's okay.
Are there any questions in Kirksville?
My question was, in your study, when you were looking at sleep apnea and in individuals who had Alzheimer's or dementia, did you also find an increased incidence of stroke in those individuals who had the apnea?
In our patients, in this sample, we did not, but there's no doubt that apnea increases the risk of stroke. Many, if not most patients who are stroke patients have sleep apnea, and the data suggests that if you treat the apnea, it reduces the risk of future strokes.
Thank you for your presentation. That was really great. So my question is not necessarily on medications or sleep apnea. It's the act of yawning. What does that do to your cycle, and why is it so contagious?
No idea. Don't know. We seem to yawn more when we're tired. We seem to yawn when we're not tired. Know almost nothing about why or what. I don't have an answer for you.
I was very surprised by what you said about being able to use CPAPs with people that have Alzheimer's, because it seems to me the average person cannot use a CPAP.
Right.
And the compliance with that seems extremely low. And so...
so how did we do it?
do you have, how did you do that? But do you have suggestions
I do.
in general?
I do. So I should tell you that we actually looked at compliance, and in our AD patients, they wore it on average about 5.5 hours, which is what you see in the general clinic population as well. So they really did tolerate it. With our AD patients, we also, as part of the inclusion criteria, they had to have a caregiver living at home, and with them, the key was teaching the caregiver as well as the patient, so the caregiver could help them with the mask, et cetera. But in general, it's all about finding the right mask. There are hundreds of different masks out there, and people go and they have no idea which one to pick, and they pick one, and then it's uncomfortable, and then they stop using it, and that's that. We follow our patients very carefully, and if they're not comfortable with a mask, we give them another mask, and we keep doing that until they find a mask that they're comfortable wearing. We also have our patients practice wearing the mask, not hooked up to anything during the day. And the example I use is, remember the first time you put your glasses on, how weird it felt? Now you don't even know they're there. That's the way you want your mask to feel. So the more they practice wearing that during the day, the easier and more comfortable it becomes at night.
It seems to me that it's not just the mask, but it's partly the hose, the tube, and the way that that pulls. It continues to move the mask. And are there any devices that can somehow prevent that?
So there's not much you can do with the hose, but again, it's about the mask. So if it's pulling your mask off, it's the wrong mask. So finding the right mask that fits you well helps with the leaks, helps keep it from moving off your nose as you're turning around, as it hits the pillow, etc. It's really all about the mask.
I take it that there's a question in Kirksville?
My question was about sleep studies. So do you have a preference on home sleep study versus in hospital? And, you know, we know that hospital studies are better, but do you have a preference by how much, or?
Yeah, I don't know that they're better. It depends what you're looking for. If you're just looking to screen sleep apnea and nothing else, then a home study is perfectly fine. And we use them a lot with our patients. I should also say that our lab was one of the first in the world to use home recordings, so I feel very comfortable with them. The time to use a lab recording is if you want more than breathing. If you're looking for leg movements, if you're looking for narcolepsy, if you're looking for REM behavior disorder, if you don't know what's going on with the person's sleep and you're really trying to determine that, then a lab study is better. The home studies for me are primarily for when you're pretty sure it's just sleep apnea, or you want to rule it out and you're not concerned about other sleep disorders.
Great, thank you.
You're welcome.
You did a brief teaser about melatonin and jet lag.
Yes.
Can you mention just a little bit about that?
Yeah, so there is a new app which I highly recommend. So let me back up. So melatonin, as you saw, can be used to shift rhythms. And so you can use melatonin when you're traveling to try to shift your rhythms to adjust faster to your new time zone. But light works even better, because light is the strongest cue our body has to know when to go to sleep, when to get up, and for shifting rhythms. And there's a new app called, oh my God, Rooster Jet Lag, or Jet Lag Rooster, something like that. I just downloaded it. And you put in your time zone, you put in where you're going, etc. Jet Lag Rooster. It will tell you exactly when you should get your light exposure and when you shouldn't, to help shift your rhythms. And light, even better than melatonin, is the best way to deal with jet lag. Sure.
How do you deal with long travel and jet lag for someone who has sleep apnea?
You take your PAP machine on the plane with you, and you wear it on the plane.
Do most planes have problems, airlines with batteries?
Some do, some don't. If you're lucky enough to be up in business or first class, you can plug it in, and then you don't need the batteries. If you're in coach, it's a little harder. There are also, by the way, now new PAP machines, which are very small, made for travel, that are battery operated. And so that's a little easier to travel with than taking your big one. But you should always take it with you and try to use it on the plane. Yeah.
Is part of the problem that we're all trying to make people sleep at the same times? That our society is kind of intolerant for different sleep cycles?
Yeah, that is.
My boss calls a meeting. He doesn't ask me what my sleep cycle is.
Right, he calls
just
it
sets
for
the meeting.
8, be there at 7:30, whether you're an owl or not. Yeah, that is a problem. The problem's even worse than that. It's not just that we're not looking at people's individual preferences. It's we're not thinking about sleep at all. Our society doesn't prioritize sleep, and that's the bigger problem. We're a 24-hour society. Sorry, I don't mean to ignore you guys over there. We're a 24-hour society. You can go shopping in the middle of the night. You can go on the internet and do whatever you want in the middle of the night. And it's too tempting to do all these things rather than sleep. Sleep gets in the way, right? It's a waste of time, people say. And what they don't realize, and I mentioned this, I think, in one of the morning sessions, is if you get a good night's sleep, you are much more efficient and get much more done than if you try to sleep deprive yourself to try to get more work in. We have to learn as a society to prioritize sleep. It is as important as drinking liquids and eating. Right? And that really is the bigger problem. But you could talk to your boss if you're an owl and that's an issue, yeah.
Yes. You mentioned lights. Do you have a recommendation that you feel is better, because there are so many out there?
I'm sorry, I missed the beginning. Of
You
light
mentioned-
boxes, did you
Yeah,
say?
light boxes.
Yeah. So in full disclosure, I have worked in my research with Lightbook, Inc., L-I-T-E book. They gave me a lot of light boxes to use for free, so I happen to like their boxes. But truly, it doesn't matter. The key is, I prefer full spectrum. Some people prefer the blue end of the spectrum. With older adults, it has to be full, because the lens yellows as we get older, and it blocks the blue. So any box that you're going to actually use, that you're comfortable with, some are bigger, some are smaller. You want a higher lux level, if possible, because then you can use it for a shorter time period. I think 5 or above, you're good. And then you only need about 30 minutes.
Could you speak to that use of light if you're deprived of getting out to light because of your schedule?
Yeah.
You're inside all the day.
Almost all of us are light deprived. We've done studies showing that even in San Diego, which is like here in Arizona, where we have sun most of the time, we spend our days in rooms like this. We're not outside, so we're all light deprived. The key is get out more, and if not, and you're having problems, then yeah, get a light box. Get a light box and set it up in your office, set it up at your breakfast table, get your light. But it's so much nicer being outdoors in the sun, isn't it? Yeah. Again, it's priorities. It's setting those priorities.
Any additional questions? Oh, Christopher.
Yeah, we've got one, Elton, from the live stream page. It says, what recommendations do you have for patients who work shift jobs that involve overnight shifts? And then follow-up, how has personal technology impacted sleep patterns? And do you recommend patients experiment with taking a technology holiday early in treatment?
Okay, so let me start with the second one first. I recommend patients take a technology holiday every day of the year. You shouldn't be doing anything with technology close to bed. And as I said earlier, none of that stuff belongs in the bedroom. So we're too tied to our phones and our iPads, and we've got to break that when it's time to go to bed. Shift work is much harder. I think I talked about this in both morning sessions today. What we recommend for our shift workers is, A, they make their environment as bright as possible at night. So if you're a nurse at a nurse's station, you can do that. I spent a lot of time working with police officers. It's a little harder. You can't have bright light in your patrol car, but you want to try to get as much light as you can while you're working at night. You want dark sunglasses on the way home to start fooling your body into thinking it's nighttime. You want blackout curtains or a good mask in your room, and you want to split your sleep so that when you come home in the morning, you sleep for about 4 hours, and it's really hard to sleep much more than that anyway in the daytime. Then you get up, you do all the things you need to do, and in the evening, before you go back to work, you go back to sleep for another 4 hours. So you're getting your 8 hours, you're doing it in 2 bouts. And that allows you, A, to recover from being up all night, and then also make you more alert in the evening when you're ready to go back to work. It also makes it easier, since all shift workers try to reverse on their days off. So when you're on your day off and you don't have to work the next night, you can sleep your 4 hours in the morning and then go to bed at a normal time that night, sleep all night, and then it's easier to get back into that normal cycle. But shift work is very difficult. It's very hard for people to be going back and forth all the time.
I've heard this, but I don't know if it's true. So is it true that your quality of sleep is better before midnight or before 2 o'clock? Or is quality of sleep pretty much a factor of the individual as opposed to the environment or the time of the day?
Well, the environment will help.
Okay.
The time of day does matter. I mean, your sleep quality will be better when your body wants to sleep, which is generally at night than in the day. But before midnight or after midnight doesn't matter. Your sleep cycle is such that your deep sleep tends to be in the first third of the night. Your REM sleep tends to be in the morning hours, in the last third of the night. So it depends how you're defining quality. You know, if you like your deep sleep better, then that's going to happen probably before midnight or a little after. But REM's just as important. All the stages of sleep are just as important for good sleep quality.